I'm going to try to rocket through this so that we can leave time for questions. Fortunately, I think I can because, like most excellent research, this paper is relatively simple, at least in its demonstration, if not in its execution. I'm sure it was incredibly complicated to pull off. This paper is by Roberta Kapp and her colleagues at the University of Colorado. You're fine. It's called Coordination Program Reduced Acute Care Use and Increased Primary Care Visits Among Frequent Emergency Care Users. It was in Health Affairs last year. It could be the setup to a joke that I don't know the punchline to. But it involved a massive amount of coordination across the community, and I think that's one of the take-homes. What they did is they built this Bridges to Care program. It's an ED-initiated, ED-based, multidisciplinary program that takes place not in the emergency department for the most part, but out in the community. They created it with the help of the Camden Coalition, of hotspotting fame. They targeted high utilizers in their emergency department, which they defined as 2 or more emergency department visits over the last 6 months, which is an amateur in our department. They provided 60 days of comprehensive wraparound services delivered in the community. So home visits if the patients were housed. They would find them in streets and encampments if they were not. They had actually family practice docs coming to the house. They had lots of home nursing, wound care, medication administration, and teaching. It was comprehensive services for 60 days. They compared these outcomes to non-random controls, patients who presented to the emergency department and would have been eligible, but there were no study personnel available, or they refused to be enrolled in the comprehensive services, or other things that made them non-random controls, which I think is a shortcoming of the study, but I can't think of how to do it better. And then the outcome they looked at was health services utilization over 90 days, 6 months, 9 months, and a year. I think that what's truly notable about this paper is that it's a novel intervention based in the emergency department, and the amount of collaboration it required could only be done, with the kind of platform that Dr. Kapp has, which is both as an emergency provider in an emergency department, working on the front lines, and also working with the state Medicaid system. The limitations are that the follow-up is limited by participating institutions, but like many communities, EMS knows where to bring which patient. And so I don't think that that's a huge weakness, although if they were able to get comprehensive follow-up data, I think it would have strengthened the findings. I think the comparator is a problem. Creating propensity scores is not a perfect solution for randomization. It's it's a kind of a pale imposter, but it's an attempt. So what did they find? They found a 30% relative decrease in ED visits. They found a 15% decrease in inpatient visits, and they found that primary care provider appointments more than doubled among intervention patients compared to controls. When they looked at a pre-specified substratum of patients with primary mental health problems, all those findings intensified. And then when they looked over time, you can see that the patterns maintain across 1 year, and in fact, they get larger. They go from an effect size of minus 50% to an effect size of minus 150. Oh, no, these are absolute days. I'm sorry, these aren't relative days. These are absolute days. So minus half a visit less in the intervention group at the beginning in the first 90 days, and over the first year, a 1.5 visit per enrolled. Hospital admissions equally got better over the year, and PCPs equally also got better over the year. So what do we learn from this study? That we are not bystanders. We have the agency and the capacity and the skills to get out of our emergency departments into the community and work with our community partners, because frankly, people have voted with their feet, right? They're in our emergency departments. And if we don't, if we wait for the medical care infrastructure to get fixed, we're writing off a whole generation of patients. So they're in our emergency departments. It is incumbent upon us to create a system that meets their needs. Dr. Kapp and her colleagues have done that. But it involves a lot of work. I see Dennis Shea in the back. He's accustomed to this work. He has built a lot of partnerships with community partners. And I thought this was a particularly compelling excerpt from the paper. To reduce the use of acute care, outreach, and enrollment of high utilizers had to happen in real time in the emergency department. That's where they are. And that's where we are, fortunately. So I think we have, actually we probably don't have time for questions, but maybe one or two until they kick us out. Any questions or comments? Well, very good. We'll finish. Suman, did you?
All the articles that you did review, is there a list of that that we could find?
Yeah, I don't know if there are any of the hard copies left at the back desk, but there is online attached to the announcement for this event. There is an online version of the hard copy, and then we'll post it. I'm not sure where. I guess probably at the Levitt Center website. Well, all 13 papers that we selected, yeah. Oh. Yeah. What, am I missing the question?
Like the larger sample, your search.
Oh, no. That wouldn't be valuable to anybody, I don't think. Sorry.
It wasn't terribly systematic.
Yeah. That's a great point, though, because that's what we would like to work toward for this event, and for maybe a product, an annual product to come out of this, which might be a paper. But that would require a very rigorous systematic search strategy and a process akin to a systematic review. We had another hand raised over here.
Just two questions. That's a great presentation, thank you. So one question was, did this increase the length of stays of these patients as they were identified in EDD, or were the patients identified after they came to EDD? And the second question about funding. So how much funding did you have to provide, or would you get the funding for the case managers, for the social workers, and other community?
Yeah, I don't know that much about how she funded this. I know she has federal funding, but she also operates the state Medicaid office. So she was able to use Medicaid funds to redirect them, because ACA now pays for community health outreach workers. So given that they were coming out of FQHCs that she'd partnered with, she had that funding mechanism to use. As far as length of stay, from reading the paper, the enrollment procedure sounds very straightforward. So I don't think they tried to do that much in the emergency department other than enrollment. Any other questions or comments? Well, thank you very much for coming, everybody. Thanks, Jahan and Ewan, and hope to see you next year.